Good evening, everybody. I'm Stephen Pallett's candidate for House District 6. I'm joined this evening by Dr. Mark Levandovsky. He is a good friend and a real expert in an approach to healthcare that I really value, in a healthy lifestyle and approaching healthcare from a really different way. And I hope that through this conversation, you'll get to see that viewpoint. At the same time, we still are living in this challenging time of COVID-19. And I would be remiss if we, look away from that. I don't want, the media's focus to change what is really important and where so many people that I talk to in our district are concerned. And that's why I brought on Dr. Levandovsky to really help answer those questions, to give people the comfort and a chance to ask the questions that they need to have answered as we address this crisis. To me, the biggest question that I think people have is, as we come out into kind of this phase 2 life, what are the chances of someone really getting this virus and transmitting it to somebody else? That's what the question that I hear the most, that I would love to hear from you about.
Thank you, Steve. Thank you for the introduction. Absolutely. And to echo some of the things that you've been saying, that question, what are my chances of getting sick? I've heard so much. I've heard it way more than I've actually seen sick people. I've seen a number of cases with COVID-19, but what's much more prevalent, what's much more common is the fear and anxiety of the unknown. So I think it's super important to tackle this question because, if we let our nervous system run amok, then, that's just not a healthy way of approaching this. So to really address the question of what are my chances of getting COVID-19, what are my chances of, getting sick from it, being hospitalized, or even dying from it, we need to understand how infectious the agent is. So that's what's called the R naught. So if Joe were to get COVID-19, if he got it, say, 3 months ago, he would have infected between 2 and 4 people. He would have been completely asymptomatic, infecting people for an average of 5 days before having any symptoms whatsoever. Now, if the same Joe had been exposed to the common flu, then instead of infecting an average of 3 people, he would have infected 1.3 people, and he would have developed symptoms within a day to 2 days. So what we know is the longer someone is asymptomatic but infectious, and the more people we infect, the higher the rate of spread of this virus. So I'm going to give a very dangerous sounding number. It's been projected because of this high infectivity and long incubation period that upwards 70% of us and the world will have COVID-19. Now, that sounds, again, like a super dangerous number. 70% is a huge number. But what we have to keep in mind is that 70% of us being exposed doesn't mean that 70% of us will get sick. And to tackle that question, we should look at, what the Chinese experience has been, with some, caveats and adjustments, to see what, of the people who got sick, what were the outcomes? So let me actually do a screen share for that, because I think that will be a little bit more telling than just me explaining everything with my fingers, which sometimes works.
Certainly.
But it's helpful to use some figures. So let me see how savvy I will be with this. Let's try that. Can everyone see the screen? Yeah.
Yep.
So what we're looking at is the rate of mortality reported in Wuhan, China, looking at some 45,000 people. And what's very important to outline is that this is a crude mortality. Crude mortality means that if I'm an 80-year-old man and I'm sick enough to merit coming into the hospital and I get admitted, I have upwards 15% likelihood of dying from this virus. If I'm a 50-year-old woman and I'm sick enough to come into the hospital, I have about 1.3% likelihood of dying. Now, this doesn't address the question that we were asking earlier, meaning if I'm 80 years old, what are my chances of dying from it? This figure shows that if I'm sick enough to come into the hospital, upwards 15% will die. But what we now know, and so initially the very scary numbers that were coming out were, if you're 80, you have a 15% chance of death. If you're 70, you have an 8% chance of death, etc. For a sort of an average death rate of 2.3%. But that was 2 to 3 months ago. What we know now is that the vast majority of people who are even octogenarian plus will not have symptoms and will not be sick. So only 50% will actually have significant symptoms. So this rate of 15% is actually halved. So if you're an 80-year-old man or woman, you likely, and if you get the virus, your likelihood of getting significantly sick and dying from it is 7.5%. The same is true for the rest of the numbers. And the younger you are, the more likely you are to have no symptoms. We know that from largely from, say, New York, from labor and delivery wards, women who were 20 to 40 who would come in for the birthing process, they would have to be mandatorily swabbed to see if they have the virus, and 88% of them were completely asymptomatic. So we know that if you're in this earlier age group of 20 to 40, you probably have a 90% likelihood of having been exposed to it, harboring it, and having zero symptoms. If you're in the sort of middle echelon, so 50s to 60s, you probably have, 25 to 30% likelihood of having symptoms. So 2/3 will have no symptoms. If you are in the 70s to 80s, probably 50-50 will have symptoms. So that means that this mortality of 2.3% is completely overstated. So for the US, with a population of risk, at risk of about 250 million, because under 18, it doesn't really affect us. We are really looking at a death rate between 0.1% and 1%, which is drastically different than the initial rate that we were seeing, rate of death between 8% and 10%. And now the CDC is actually touting that the death rate seems to be close to 0.25%. So that's for individual risk, right? So if you're a healthy 50-year-old, your likelihood of really being sick and dying from it is quite negligible, quite low. Now, if you're a population, then even 0.25% of the Americans dying is a huge number. It's a huge number. It's not something that we want to take lightly, and it's not something that we want to just dismiss.
Absolutely.
And frankly, our medical system is not really prepared for it, right? So the whole point of initial social distancing is really, and I think that speaks to a campaign, Steve, is an issue of social responsibility and civic duty, right? We, the younger folks, unless they have significant comorbidities, will have, negligible risk by and large, but they certainly would be in a change of transmission. And that's the reason for the masks. That's the reason for 6 to 8 feet. That's the reason for very measured guidelines for reintegration. And that needs to be emphasized. So so I'll probably pause here to make sure that we have no specific questions, because what I want to do at this point is sort of switch from individual risk to more population risk and talk about how is it that we get reintegration into the world. So let me pause for a bit, and I'll stop my screen share.
Sure, and when I look at some of those the concerns that I hear a lot are from people that are in those age ranges that are have a higher risk of illness and potential death. Even at a 7.5% number, that number is still very high. When it comes to transmission, I've heard things about super spreaders or things like that. What is someone's risk in really transmitting it to their grandparent when they go to visit, or a parent when they go to visit? I think that's kind of one piece of that I just want to clarify before we kind of head on to the next part of the conversation.
Right, and that's a great question. I think it needs to be emphasized that what we know right now is that the more symptomatic someone is, the higher the chance of infecting others. So if I have minimal to negligible symptoms, I'm still shedding the virus, but I'm certainly not a super spreader. You know, if I am, and remember, most of the people will be symptomatic within 5 days. The range is anywhere from 2 to 11 days. That's about 95% will be contagious, but an average and most people will be, 4, 5, 6 days. So it's not like you need to quarantine and isolate yourself, for 3 weeks as we initially thought. So the bottom line is the more symptomatic you are, the more likely you are to have a higher viral load and disseminated, both as particles, so spread of the aerosol particles, as well as contact. If someone's, what's also been clear, however, and that's sort of a prelude to the question of testing, is that, well, we said, well, it doesn't really make sense to test, because if we do, say, antibody testing, and someone had the disease, we don't know if these antibodies mean that they're immune. So in other words, if they have the disease, developed an antibody response, can they still transmit this thing to someone else? Will they have symptoms? And what we now know from, again, mostly Asian countries, several hundred people, that once you've developed an immune response and might have been re-exposed and swapped positive for the virus, you have, from what we're seeing, 0 symptoms and no transmissions. And that again bespeaks to the fact that the lower the viral load, the fewer the symptoms, the less likely you are to infect others. Hopefully that helps and clarifies it a little bit. Yeah.
Absolutely, absolutely. And so, this has been in our country now, I think they're saying for upwards of 5 months. And, people in Denver were a very active city. And I think people are wondering, what does it take to really be able to reintegrate to a normal life? What does that path look like? And, from your perspective, medically, what does that look like? What are we looking at realistically to get back to? Are we looking at a new normal? Are we going to get back to the way things were? What does that look like kind of in the immediate future?
Sure. It's, as we were saying, when can we have play dates? When can we have company over? So for sure, when can we have, an easy integration back into the workforce? And the simple answer is herd immunity. When we've had enough exposure to the virus to have herd immunity of about 60%, we can basically reintegrate more or less normally. And so 60% figure is basically, it tries to ensure the best we can so that if one person is infected and he infects his neighbor, that neighbor is more likely than not to have immunity. And then the chain of transmission is broken. Now, there are 2 ways of doing it. One is through just plain exposure to the virus so that you develop a normal, natural, innate antibody response, or a vaccine. We know that on average, a vaccine development is about 18 months. That's sort of the common path. Because of all of the haste that's associated with the current development, it's been touted that we might have it by the end of the year or maybe beginning of 2021. And, if a vaccine is available that early, I would only be comfortable, offering it to folks who are at higher risk, because the faster we get the vaccine on board, the less testing we do. And we can think of the swine flu and all the pandemics with, Guillain-Barré's that happened. It's not a benign thing, but certainly for a population at risk, it would be meaningful. Now, short of a vaccine, what we need to do is really to have a reliable way of identifying who's been exposed and who's had immunity. Because recall, what we now know is that if you've been exposed and you've developed an immune response, you pose no risk to others, and you pose no risk as far as reinfection for yourself. And in all fairness, if I if we look at Joe, right, who had the flu virus, and he had a vaccine for the flu, and then he comes into my office regularly and I swab him for the flu, every week, it is very possible that I'll pick up some of the influenza virus. But if I do, he will have almost no symptoms, and he would not be contagious. So the same thing is really being true of the SARS-CoV-2, which is the causative agent for the COVID-19. If we serially test someone, we can pick up the virus, but that virus should be of no consequence. So I think the next meaningful thing is to really talk about antibody testing.
Sure, and I think that was kind of how we initially, when we were first talking about this conversation. We had talked when I came in for my antibody test, and you drive through Denver and you see urgent cares, you see signs posted outside of different medical facilities. We have antibody tests, finger prick, 3 minutes and you have results. And from a consumer protection perspective, that's what is a good antibody test? Is everything out there reliable? Can you really go for $59 to your local urgent care and get a reliable test? What does that look like, and what is the meaning of a positive antibody test for when done correctly?
Sure, excellent question, and I think this speaks to the fact that there are, I think, upwards of 300 options for antibody testing now available. And in all fairness, part of this confusion just comes from the fact that the FDA had to relax its stringencies initially because there was just such a huge demand. This virus, as far as we knew, didn't exist as of 6 months ago. At least we knew nothing about it. So there was just, fountain, eruption of options. What's super important to understand is that not all antibody testing is created equal. It really has to do with two parameters: what generation antibody testing and how prevalent the condition is in the locale where we're looking at. So as a matter of fact, I had a phone call from a rep that was selling a rapid antibody test, and he was actually promoting it here as well as in the New York tri-state area. And what he was telling me is that, but my docs, in New York love this test because it's, it's very reliable. And what we ended up talking about is that you really have to understand what the prevalence of the condition is in New York and compare it to that of Denver and, say, Pueblo, to understand how good a test it is. Basically, the more common a condition, the crappier the test you need. So think of it like looking for a needle in a haystack. If your haystack is mostly needles, a crappy magnet will do. You don't need to have a T3 Tesla MRI magnets to pull out that one needle. But if you have very few needles in that stack, you need to have a highly precise magnet. So the same is true for the coronavirus testing. If you have a test that is sort of doing okay, but the condition is very uncommon in the population, it's going to be a very poor test. And again, I'm very good using my hands, but let me actually switch back to a few slides and show you that, because I think that will be a little bit more helpful. So I'm going to go back, screen share, and address that in a little bit more detail. And it is this one, I think. Okay, so we're okay? Can you see my screen okay?
Yes.
Perfect. So this is a test that I'm using, and I've broken it down to walk us through 3 generations of antibody testing. So the first generation of antibody testing that came online was one protein that is depicted here and one antibody. It made sense to use this antibody called IgG because this is an antibody that suggests a long-term immune response. So if someone's negative for this antibody screen, we think it's a wonderful result. And what's been touted is that the sensitivity of this test is upwards of 90%. Now, what I need to emphasize is that sensitivity and accuracy are 2 very different things. If something is 90% sensitive, depending on how common the condition is, it could be only 32% accurate. So when the condition is very uncommon, and it was very uncommon in the beginning of the pandemic, That's what happened to the European Union. They ordered a bunch of IgG1 protein test kits or rapid test kits from China that were touted to have sensitivities of 80 to 90%, and to a common mortal it would sound great. It's accuracy of 80 to 90%, but that's not at all what it means. It means that given that only 5%, 5 to 10% of the population had the virus at that point, its sensitivity of a test at 90% meant that it missed 2/3. So then,
wow, that's pretty remarkable.
It's huge, right? And it's so many of these drive-through tests that are available through urgent care, through concierge clinics, really have sensitivities of around 90%. So please, please, please do your research. One, figure out how common this virus is where you live. It's going to be very different in the Denver County as opposed to be in, even in Arapahoe County or in Pueblo County. And in New York is going to do much better with a test that's 90% sensitive than Nebraska, just because the condition is way more common. But basically no one's using a first generation test anymore because it was frankly so crappy. And what many of the urgent carers have is really a hybrid between first and what we call second generation test. And the second generation test use the IgG antibody response, that is longer lasting response. But said, let's also look at the earlier response, which is IgM and IgA. Those things, those antibodies appear usually within a week. And if we combine all three antibodies against one protein, you have about 95% sensitivity, which sounds super impressive. But again, with low prevalence of 5 to 8% of COVID-19 in the population, 95% sensitivity translates into 50 to 60% accuracy, and that's the bottom line number. The test that I'm using is basically all of these. It's 4 proteins, 3 antibodies. And the reason for that is we have the most comprehensive picture this way to see what the progression of infection is, how early someone is in the course of infection, and gives you the best sensitivity of 98%. Now again, sensitivity is not accuracy. With 98% sensitivity, you're looking at accuracies of 80+%, and now in the Denver County, we probably have a prevalence of COVID-19, so of about 15%. And again, we know that for birthing moms, so like CU swabs are also mandatory, and talking to my OB colleagues and gynecological colleagues, when they swab their birthing moms, about 12 to 14% swab positive, again, completely asymptomatic. And talking to my colleagues at nursing homes, because they have to mandatorily swab and test their employees, about 14% are also positive. So with a 14% prevalence, a test that's looking at 4 proteins, 3 antibodies, 98% plus sensitivity, it'll be accurate in over 90% of the cases. And what I'd like to show you is actually a clinical case of what that looks like. So let's look at a patient. It's a father who, so it's very interesting. I've been testing some of my patient families, because you can see who has a better immune response. You can see what the symptoms were, and you can sort of see who was the first one, who they transmitted it to, and who is the last in the chain. So this is the 0 case. This is the father. He had a known exposure. So IgM response is the early response. He was tested about a month out, and you expect the early response to be negative, and he was. Late response, all positive. IgA response also suggests that he had a fair amount of diarrhea and upper respiratory symptoms, and he did have all of those things. And he transmitted it to his son. And you can see that he was the second one in the chain of infection by seeing that one of the IgM responses is still positive. He was about 3 weeks out. And what's fascinating about this particular case is that looking at the comprehensive 12-point system, right? So it's four proteins, 3 antibodies, you have 12 variables to look at. It's very clearly positive, right? He has immunity, he's been exposed. But let's say we only used a second generation test. If we used on the sun a second generation test, at best, this would have been equivocal because of the positive IgA, or most likely, it would have been interpreted as negative. And don't take my word for it, we actually did test him with a commercially available test. And here it is.
Wow.
All 3 were negative. So I can't underestimate and underemphasize, not all antibody testing is created equal. It is super important what you use and how you interpret it. Super important. So you need to look at the clinical picture, and you need to have, basically, don't settle for second generation tests. Really try to, really try to go for the third generation test. Let me pause here and again, open it.
Sure, and I have a question from the audience here. When it comes to evidence-based responses, what can you talk about based on evidence that the production of antibodies from exposure to COVID-19 actually equates to immunity, or is that something that is really still an unknown?
So it depends on how rigorous we want to be to answer the question. And to really fully answer that question, we need to wait 2 to 5 years, right? Because only at that point will we have sufficient data showing, thousands, if not millions of people showing, okay, antibody response, immunity down the road. We don't have the data yet. What we do have, and I mentioned that earlier, is data from about 450 people in initially reported in China and then South Korea that looked at swabs for COVID-19. They tested positive, then they were shown to have an antibody response, and then they were serially swabbed again. And a number of those people would again swab positive for the COVID-19 with a positive antibody response. But 0 of them had symptoms, and there were no documented cases of transmission. So I think that's as close to as evidence we have that antibody response translates into immunity, 1. 2, if we think that antibody response means nothing as far as immunity, then we really can't talk about a vaccine. It's an oxymoron. And we really can't talk about herd immunity. Like if I say that my antibody response means nothing, but I need to wait for herd immunity of 60%, it's a contradiction of terms. How can I have herd immunity if my antibody response is not protective? And if it's not protective, then why is it that we're using plasma from sick donors to treat with antibodies the people who are sick? Right? The whole thing makes no sense. If antibody response means nothing, it means we can't have a vaccine, it means we can't have a herd immunity, and we certainly can't be using the plasma, isolated plasma for convalescent plasma for treatment of sick individuals. Hopefully that answers and sheds some light.
I think so, and if there's a follow-up, I'm happy to continue to pass that along. I think the second piece really is, do we have enough of these tests to be able to give them to people in the Denver metro area, in all of Colorado? Is that a possibility that's realistic with those third generation tests?
Sure. So I can't speak to, the whole Denver County of 3.5 million. But what?
I have a visitor here.
Yes.
I apologize.
It just came to that's okay. So I actually had that very same conversation with a good friend who was running a number of nursing homes. What they do for nursing homes is that they PCR test everyone. So they swab for the active presence of virus every week. And they're saying, well, there's no end in sight for this because it just sort of ad nauseum, right? You just swab and swab and swab and swab. But it makes really no sense because there is no end point, right? If you swab for active infection and you know that a growing population, growing part of the population is becoming immune, you're just ultimately wasting tests. Because initially only 5% of the population is going to be immune. Then it's 10, 15, 20. In New York, it's 30 plus. So you don't need to swab that third plus of the population to see if they're, if they're actively infected. You need to see if they actually have the antibodies. So there's been really no shortage in my practice of having these tests available, and the turnaround has been down to about 3 days now. Certainly with the slew of various antibody tests available, one can certainly start with a screener, like a second generation test, and if there are any questions whatsoever, then you can upgrade to a third antibody test. But ultimately, I think you need to rely on the most accurate and comprehensive test. And we've seen no shortage. I haven't tried to offer this to 3.5 million people on that hand.
Sure.
Run into some logistical issues.
Absolutely. And, then, kind of moving that to the next, to the future, when it comes to contact tracing, is that something you can kind of speak to? Is that something that, you really need to see the antibodies in order to be able to really know, or are there tests that are just as accurate in testing whether someone actively has the virus and maybe shedding it? Do you need that combination to have successful contact tracing?
It's probably a combination because, again, testing families, I'm seeing this amazing difference. So in that same family of the gentleman I showed you, his son, it's a family of 5. The wife and one of the youngest sons were tested several times, and the son was negative, and the wife only had 1 antibody response. So again, we know that, between 50 to 90% of people will be asymptomatic. And it's very possible that they will just have less of a viral burden. And they will be, if they are symptomatic, so if they are contagious, it might be just for a day or 2 as opposed to 5+. So it would be very important to not only trace the contacts, but also look at the point person and see, well, how exuberant of a response did he have or she have, right? That combination of factors would really give us much more valuable information to see how much they, people who came into contact with them were at risk.
Fantastic. I really appreciate that. And I'm actually really fascinated with, that family example, because obviously a family living together, they're sharing food, they're living in close quarters together, air conditioning, all the different things that we hear about when we hear about the spread of the virus. And I think that's a really powerful example to kind of see the breakdown of how it translates to both positive tests when it comes to antibodies and symptoms as well. So I really appreciate you, sharing that perspective and that kind of concrete example with the data to understand how that played out.
And actually speaking to the family, and I think extrapolating to our population at large, what I'm seeing much more of is people being proactive about their health and wellness. And that really didn't used to be the case even 4 months ago. And one of the remarkable differences about the 2 out of 5 people in the family who were asymptomatic and had very little in a way of antibody response, I think, is they're healthier. If I look when I looked at their degree of inflammation and comorbidities and medical problems, it was drastically different than that of the father and some of the other sons. Their body habitus, their body weight was quite different. So what I think this is coming to emphasize, and this is probably the most important take home, this is an amazingly important wake-up call for us as a country. We know that over 90% of people who will have symptoms will have comorbidities. Things like diabetes, obesity, hypertension, they double to triple one's risk of having exposure and symptoms. So we can't control who we're going to come into contact with. It's just not possible. But we can certainly create this safety net, this that helps us through the trapeze of life, so that we're able to better accommodate for the inflammation, for the irritation, for the vulnerability of our system, our body system, to succumb to an infectious agent or a cancerous agent or cardiovascular agent. There is really a common denominator. I was listening to this fascinating talk on clots and heart attacks in the presence of COVID-19, and everyone was saying, "Oh my God, this is a heart killer, basically, and a clot form or type of a virus." And what was very important to emphasize is that if one looks at the week of an exposure to influenza, which is the common causative agent of the flu, if you look at that week of the influenza and you compare the rates of the heart attack during that week to the week before and the week after, during the week of the influenza, people have a 7-fold higher rate of having heart attacks, 700%. That risk vanishes the week after, and that risk wasn't there the week before. So is this the influenza virus that is such an evil virus that's doing it? And the answer is no. The influenza virus is just, it bespeaks to our weakness in the system. It highlights our vulnerability, lack of resilience. Basically, most of these conditions that plague us, from cancer to strokes to heart attacks to clots, is a exuberance of inflammation. And when we have a super high inflammatory response to begin with, it doesn't take a whole lot to tilt us over the threshold. And that's what the influenza virus is doing. And that's for sure what we're learning about the COVID-19 SARS-2 virus as well. So the take home, and I think that's the most important thing, please take a chill pill. This is not, the plague of the 1600s, but please, please, please start attending, very proactively, very mindfully to your health, not just saying, "Oh, I'm going to take care of it when I get sick," or "I'm not feeling bad enough to go see a doc." Like, start seeking out those services and take care of your health.
Thank you. And thank you for that closing point. I think that, again, Colorado is all about the healthy lifestyle, but also really being sensitive that as we make personal decisions about how we resume normal life, still being careful, still focusing on washing our hands, and still focusing on wearing a mask, when appropriate. If you're working out in your house, don't wear a mask. I've seen people overheat from that too. So really just, being careful when you're outside, wearing a mask, when you're after you go out for the day, washing your hands, being careful is just so important. And I really appreciate Dr. Levandovsky for you coming on tonight. Dr. Levandovsky is, again, the founder, medical director of preventive medicine and cancer care in the district. He and his family live in HD6, and he's really been just a great voice to me on thinking really carefully, evidence-based thought on how we approach this virus and moving forward. And I'm so appreciative of his time for joining us. And we are about a week away from ballots dropping. And for all of you listening, I urge you to cast your ballots for ballots when you get your ballot just a week from now. So thank you, everybody, for listening, and have a wonderful evening and enjoy the rest of this wonderful day. Bye, everybody.
Thank you.
Bye-bye.